In this section entitled Neuropharmacology Vignettes, we'll be going over a few case studies which you might see on USMLE. In the next section, we'll discuss some vignettes that involve neuropharmacology. For the first neuro case, we have a 32-year-old male who's brought by his wife to the family care center in the community because of increasing tremors, slowing of movements, and postural instability. This patient works as a chemist in a pharmaceutical research company in California and has a long-standing history of drug abuse requiring hospitalization. On physical exam, his vital signs are normal. However, on physical exam, he has a flat facies, resting tremor, cogwheeling rigidity, impaired capacity for voluntary motor activity, slowed speech, and voluntary movements. So this patient has Parkinsonism. Some questions here. What disease would cause the symptoms seen in this patient? What is unusual about the presentation? And what do you think is the cause of the symptoms? So again, this is drug-induced Parkinsonism. There are several drugs that can cause Parkinson's disease, especially the antipsychotic medications such as haloperidol and the phenothiazine categories. These are the atypicals, antipsychotics. Reserpine can also cause Parkinsonism. This is an anti-hypertension drug. This patient, however, works for a chemical company, and the history behind his case is that he is synthesizing a compound called MPT, trying to make a designer drug of abuse. MPTP is oxidized in the body to MPP, which destroys dopaminergic neurons in the substantia nigra. This is actually a true case. The treatment for this patient is that because the neurons are destroyed by this medication, there's no therapy for this patient's drug-induced Parkinsonism except for discontinuation of the offending drug. If the neurons are damaged, then the damage to the brain can be irreversible. For neuro case number 2, we have a 5-year-old male who's rushed to the emergency department after his mother found him playing with her purse where she carries her pills, her antidepressants, and the boy apparently swallowed a handful of pills. On history of present illness, the child is complaining of dry mouth, blurry vision, and hot cheeks. Physical exam, you see tachycardia with an irregular rhythm, fever, and hypotension. On physical exam, the patient is confused with dilated pupils or mydriasis. The skin is warm and red with decreased peristalsis or gut sounds with no peritoneal signs, meaning the patient does not have a surgical or an acute abdomen. On labs, the patient's electrolytes are normal. On the ECG, we see premature ventricular contractions, which is why the patient had an irregular rhythm, and prolonged QT and prolonged QRS intervals. So some questions. What most likely is the type of antidepressant that the mother was taking? Also, what type of autonomic effects are being seen in this child, and what is the recommended treatment? So the mother was taking tricyclic antidepressants, and this child has overdosed on tricyclics. Remember, these medications are amitriptyline, imipramine, and clomipramine. The way these work is by blocking the reuptake of norepinephrine and serotonin. They're used for the following indications. The way these work is by exerting varying amounts of blockade on muscarinic and alpha-adrenergic receptors. And you can see this patient has many of these signs that we commonly see in tricyclic overdose. Overdose will resemble atropine poisoning. The treatment for this patient is supportive care. You remember ABC, airway, breathing, and circulation. And to treat the arrhythmias, possibly by giving an antiarrhythmic. For neuro case number 3, we have a 40-year-old male who was brought to the emergency room by his sister, reported that he had been dropping by her apartment acting drunk and agitated. On history of present illness, he had been diagnosed as suffering from major depressive disorder 1 month ago and had been on phenelzine for 3 weeks. What type of drug is phenelzine? This is an MAOI. The patient last week was switched over to paroxetine, which is an SSRI. On physical exam, we see a fever, 39.0 Celsius, hypertension, 150 over 100, tachycardia, heart rate 110, and tachypnea with a respiratory rate of 30. He's disoriented, agitated, and diaphoretic. He has hyperreflexia, resting tremor, and rigid extremities. What class of drug is phenelzine? As you know, this is an MAOI. What about paroxetine? This is an SSRI. Would an interaction between these two explain the patient's presentation? Well, apparently he stopped taking the MAOI before he started taking the SSRI. And what neurotransmitter is the basis of this patient's problems? Well, this patient has serotonin syndrome. This is caused by an excess of serotonin in the bloodstream. And the combination of an MAOI with an SSRI can cause serotonin syndrome. It's very important when switching from one antidepressant to another, they have to be off the first one for several weeks, especially with MAOIs, before starting the next one. Again, serotonin syndrome can be seen in a combination of MAOI plus SSRI, or one of these medications plus the following medications, meperidine or dextromethorphan. A common scenario of serotonin syndrome is an adolescent who is taking an SSRI who then takes dextromethorphan with cough syrup and develops serotonin syndrome. The treatment for these patients, again, supportive care and external cooling. We can give also intravenous benzodiazepines for agitation and seizures. This is the end of the Neuro Vignettes section. In the next section, we'll discuss cardiovascular pharmacology.